we'll move to, because we are a little bit short of time, I was hoping to save the question in the discussion. Would like to end with Durward?
Now, just a brief word, I'm not going to spend too much time on this, but airway stenting in children is quite rare. As has been discussed before, we will see of 1,000 patients that we get a year, about 2 patients will probably need a stent. We have put in about 30 metal stents in the last 13 years. We work quite closely with Greg Street. I know Martinelli quite well. But most of these, as we've said before, are children with serious heart problems, vascular compression that is really problematic. They can be in intensive care for months, and they can have death spells. And I think what's clear and illustrated in the 2 previous cases, they will die 100% without help. So we have been forced, as a last resort, if surgery and everything else fails, to put stents in. Now, historically, we only had metal stents. The principles that we have are slightly different to other places. We will try and put the smallest stent possible, because erosion, when we have a blood vessel, is a real big concern. This worries me greatly. And so our strategy has been always to put the smallest stent as possible, to not actually balloon them as they grow, and to just basically let the patient try and outgrow the stent. Historically, Palmer stents have been used, which foreshorten with time. These were just because they were around at the time. Recently, we've been using these Valio stents, which don't foreshorten, they're a bit more forgiving, but nevertheless, they're a metal stent. Here it just goes to show you 2 patients. This is one patient. We put in a bronchial stent there from birth. 4 years later, the child's at home well, but has metal in the airway. The rest of the airway has grown. This has never been ballooned or stretched or dilated, but it's there for life. This is another patient who's a dwarfism syndrome, who has malacia of the bronchi. 2 metal stents covering the entire bronchus from the start to the end. This is 4 years later, also well. The airway will grow, but the stents are there for life, and they're a problem. Now, in really difficult cases, we end up with a very difficult scenario, which I'm sure the other cases described. This is a patient with very complex heart disease. This is an aorta that's coming right on top of the trachea and the bronchus. It's pulsatile. This child has no chance to survive. We have to put metal stents in the trachea here, in the bronchus. This is 4 years later, so we just leave the stents alone. You can see the stent is pretty free in the right main bronchus. Here is the stent doing its job. There's the bronchus that's grown. That's what the stent looks like after 4 years. It's buckled, it's distorted. That's a pulmonary stent, but it's doing the job. This is what the trachea looks like. Up here, this is the aorta. And this is a small stent in the corner. If we put a full-size stent, this would erode without any doubt. The problem is this patient has got this metal in the airway with a pulsatile vessel here waiting to go off. And this is one of our big concerns, to move to biodegradable stents. And you can see, if you just look at different types of stents, the metallic strength, they are reasonable strength. We want them to break if the pressure is too high, because then you don't get erosion. They are very easy to put in. The delivery device is very simple. They're good visibility in X-rays. The problem is they are not retrievable. They are there for life, and therefore there is a big concern about safety. So we were very happy to see the use of biodegradable stents, particularly at Red Street, who we know quite well. And we had just 3 cases here which illustrate how valuable they are. This is a girl who was 12 years old, who had severe scoliosis. She went for repair of scoliosis, and when her spine was fixed straight, her lung collapsed. The bronchoscopy showed it was because of the way the heart twisted inside of her, and it compressed the bronchus to a complete slit. This is the bronchus here. The left main bronchus is a tiny hole. An Ellis stent was put in. This was around Christmas. We wanted to get her home for Christmas. She had scars down her back with wounds that needed to heal. So we just wanted a couple of months to get her out of hospital at home. And you can see technically it was challenging because there's always metal work in the way. And they're the 2 dots from the metal stent that we put in. Now I will discuss the technique we use, because we can't put these under apnea or under a held breath. We have to actually have lots of time to put them in the airway. And we will use a laryngeal mask, which is a very good way to have lots of time to put them in the exact place. This is her the next day. There's the stent, lung is open, and now 6 months later the stent is gone, she's fine. If we would have had to use a metal stent, it would have been there for the rest of her life with the problems that brings. So in this example, it is a completely curative exercise. This is another patient who's 8 years old, who has very severe complex cardiac disease. She has one ventricle, so pumping blood to her lungs is very difficult. She had left main bronchus compression, you can see here, a total closed slit of an airway. She had a metal stent put in because we didn't have biodegradables. That started to erode and bleed within 1 week. She was also anticoagulated, so we took that stent out. We put an Ellis stent in. There it is going in, all the way to the end of the bronchus, which we can see there. You can also see here we don't expand the stents big, they are small. I think this was about a 5mm stent in an 8-year-old girl, but it was enough for her to breathe. It was enough for her oxygen to pick up. It was enough to clear infection. But then 4 months later it dissolved, and we're back to square one. She can't exercise again and things like that. The problem is we can't get funding to keep putting them in all the time, which creates a problem in terms of the cost. But they certainly work for her and with very minimal risk, even with extreme pressure. Now this patient is exactly what we've described in the previous ones. This is a patient with Down syndrome who's 3.5 kilograms, who had complex heart disease but had bilateral bronchomalacia, which is probably an indication that other people have found. This patient was still ventilated with us for 200 days in intensive care. With death spells, we tried operations to fix this, pulmonary hypertension, and I think the only option this child had was a stent. So we elected to put the biodegradable stents in. You can imagine this patient, because of the pulmonary hypertension, you really can't afford to have oxygen drop or the carbon dioxide go up when you put the stents in. So we use, I'll show you how we do that. This is just to show you as time goes by what happens. And because the stents aren't put in too tight, we get not too much granulation. This is the stent at 4 months. We can still see the grids. And then literally 1 week later, the stent collapses and the markers are gone. Just to show you what it looks like, there's the 2 stents with the 2 markers. And this is what happened. The one day, we bronchoscope these kids quite often, so at 4 months, the stent was fine. The next day, these markers disappeared down the bronchus and the lung collapsed. The child ended up very sick, back on the ventilator, needing lots of help and support, and we had to go and put the second set of stents in with a patient who was quite sick. So the problem now is that we have stents that work very well, they dissolve, but you then need to keep that process up, and that's the difficult thing because the time in terms of how long they take to dissolve. But we have found them very safe and very effective. Now this is the problem we have to deliver the stent to the patient. This is the size endotracheal tube, 3.5, that would fit this patient. This is the 3mm device that we have, and you can see it won't fit in here. This is the next size up, which it barely fits in. You can't ventilate around that. And this is the tube that it does fit in, but that would be for a 1-year-old. So we clearly can't put these tubes through the endotracheal tube. So we use a laryngeal mask. This is a laryngeal mask here. It's a tube that goes into the airway, sits in front of the larynx. This is the same 3mm diameter stent delivery device with the room around the laryngeal mask. Lots of room. In fact, we can put a bronchoscope through there. Here is a bronchoscope simultaneously through, and there's the gold tip. So we can align the stents not only radiographically, but we can visually see where the perfect position of the stent is, so we can deliver it perfectly. And this has worked very well. So the laryngeal mask is now one of the favorite ways that we use to put these stents in. Technically, just a few problems that we've experienced. It's this issue here. We have the stent, we have the olive, and the problem is, number one, is that the olive is quite large, so if we have compression, it's quite difficult to pull the olive up here through the deployed stent if the stenosis is tightened. Sometimes these are vascular compression, so we have no option but to do that, and you'll see here we have, by mistake, pulled the whole stent up. There's the stent moving out of the bronchus because of this. In that case, we will then take the stent out, redeploy it, balloon this area again, and then hopefully during the balloon let a little bit more room and put a lot of gel. So we put a lot of gel on the end of the stent. The other option, just before I come there, is that the olive is quite far from the tip of where the stent is, and when we want to stent from bronchus to bronchus, we sometimes find this olive is too large to fit down here, because to align the stent perfectly, we have to have the olive positioned right over here, and we found that it doesn't fit in some children. So there is a technical problem with the length of the olive and its size relative to the bronchus in small little babies. Now people have spoken about the stents defragmenting and the gold tips migrating, and we have found in small babies, they don't cough them up, they just disappear down the lung somewhere. And you can see here a bronchogram. This is a new stent that was placed there. This is the remnants. This used to be up here, this used to be here, and these have now disappeared down the peripheral airway somewhere. We don't know where they are, we can't see them, so I'm not sure what the consequences of these things will be in time. They're very small, but they will certainly wedge in some of the peripheral airways. So if we keep repeating the stents every 4 months, we will end up with lots of potentially metal all over the place. Nevertheless, when we sum them up, we can see the Ella stents are very attractive because they may last for months. They are very safe, and I have to say the safety profile is very good, but the problem is the cost and the availability, because you may need them very quickly at some point, and because they're manufactured off the shelf, it's a problem. So this is the patient here with bilateral stents ready to go home. He's on a portable ventilator, but he will have a good quality of life. The question now we face is he's had 4 stents put in. Where do we go next? Because he will take about 2 to 3 years to outgrow his bronchomalacia, because he has Down syndrome, and there's quite a delay in cartilage development. So I think those are the main issues we face now. So we're very happy with the biodegradable stents. The loading device, if it's smaller it's better, but it's not too much of a problem for us. I think the availability is an issue, because when we have an emergency we need the stents quickly. And ideal, if they could last 12 months or something like that, that we don't have to keep doing procedures regularly, that would be perfect. And obviously at a lower cost. They have changed the way we manage patients now. Thank you very much.
Thank you very much. And the last one from the group of tracheobronchial stents, Dr. Mirabila.